Good morning, Honorable Emeritus Chairperson Sir, respected President cum VC, Vice Chancellor Sir, respected Pro Vice Chancellor Sir, senior faculty, senior colleagues and friends. To combine clinical rounds hosted by Department of General Surgery, Unit 2. Today I, Dr. Armaan Ahuja, second year PG resident from Department of General Surgery, will be presenting a case on 70-year-old male with pain abdomen under the guidance of Dr. Lakshman Agarwal Sir, Director and Head of Unit, Department of General Surgery. Our patient was a 70-year-old male hailing from Hindon, Rajasthan, farmer by occupation, and came to the surgery OPD with chief complaints of pain in abdomen for the last 1 year, vomiting for the last 2 weeks, decrease in appetite with loss of weight for the last 2 weeks, and fever for the last 3 days. The patient was apparently asymptomatic 1 year ago when he developed pain in the abdomen. This pain was in the left upper abdomen. It was insidious in onset, gradually progressive, continuous with intermittent increase in severity, dull aching in nature with sharp episodes, radiating to left flank and epigastrium, and relieved on taking oral medication like analgesics. He also gives history of hospital admission twice, once 1.5 months ago and the other 2 weeks ago for increased severity requiring IV analgesics for relief. Patient also complains of vomiting for the last 2 weeks. The content of this vomitus was partially digested food. It was non-projectile in nature, associated with nausea and aggravation of pain, with no specific periodicity and relation to eating food. Patient complains of decreased appetite, followed by weight loss for the last 2 weeks, and history of fever for the last 3 days, which was continuous, high grade, and relieved on taking oral medication like tablet paracetamol.
So, is this significant weight loss, and how do you define significant weight loss?
So, this is the patient did not quantify the amount of weight loss he had, but significant weight loss would be more than 10% of body weight in the last 6 months. The patient gives no history of dyspepsia, hematemesis, jaundice, trauma, constipation, diarrhea, steatorrhea, bleeding per rectum, burning micturition, hematuria, chest pain, or breathing difficulty. Past history: the patient has no known comorbidities. He was operated for cataract of left eye 15 years back under local block, and for this same complaint he has had 2 previous admissions, one 1.5 months ago and the other 2 weeks ago. The patient is vegetarian by diet, gives history of bidi smoking 2 bundles per day for the last 40 years, which he stopped 1.5 months ago. This gives him a total of 80 pack years, and history of alcohol intake, half bottle of whiskey per day for the last 40 years, stopped 1.5 months ago. That gives him approximately 90 grams daily. He has normal sleep and normal bowel habits. He gives no history of similar complaints in his family. So a brief summary of our history. The male patient, he's 70 years of age, he's a chronic smoker and chronic alcoholic, presented to us with abdominal pain in the left upper quadrant since 1 year, dull aching and continuous with increased severity intermittently, and 2 episodes of severe pain that required hospital admission 1.5 months and 2 weeks ago. He also gives history of vomiting, non-projectile, for the last 2 weeks following pain, decreased appetite and weight loss for the last 2 weeks, fever for the last 3 days, which was relieved on taking medication. Now I'd like to extend a question to the audience. What are the common organs and etiologies of left upper quadrant abdominal pain? Any residents who would like to answer?
Before that, going back to the question which Dr. Hemant asked, weight loss. So you said 10% of the weight in 6 months. Suppose the history is only 3 months or 1 month, then?
So still to categorize it as significant, we need about 10% of weight loss to occur.
That is the definition, 10% over 6 months. But if a patient has complaints only for 2 months, how do you characterize significant weight loss?
So it should be 10% still.
So 10% in 6 months, over 6 months, 5% over 3 months, and even 2 kg weight loss in a month. And these days you have to mention unintentional weight loss.
Unintentional weight loss, yes.
So everybody is trying to reduce weight. So it has to be unintentional weight loss.
Yes.
And here, you said that he has weight loss over 2 weeks.
Yes.
Did he measure his weight before 2 weeks and now?
Sir, he did not
So
personally.
you have to say that it is a perception.
Yes, sir.
He feels that he has lost weight, but it is unquantified.
Yes.
You have to mention that.
Yes.
So audience, physicians, surgeons, बताइए 4-5 तो निकलना ही चाहिए ना? Yeah, start from there. Go ahead. Come on.
Yes. Spleen could be a common organ.
It could originate from stomach, it could originate from diaphragm, it could originate from suprarenal glands, it can be spleen. Because the patient also has history of fever, so it could be an infective cause, maybe some lung abscess.
Cause nahi pehle, you're talking about structures, to go ahead with other structures. What are the other structures?
It could also be originating from the pancreas or the splenic flexure, or these are mostly the organs from where.
And now elaborate on the etiologies. What possible causes?
Sir, it could be a peptic ulcer disease if it is originating from the stomach. It could be a splenic abscess. It could be a subdiaphragmatic abscess. It could be inflammatory bowel disease. It could be pancreatitis. So from the side, if these organs are involved, probably this can be the etiology. Yes, sir, it could be.
Chronic abdomen.
Which complication of pancreatitis can present like this? Pancreatitis for 1 year is very uncommon, but the patient has a persistent problem for 1 year. So could there be a complication of pancreatitis?
Sir, it could be a case of pseudocyst of pancreas. Chronic pancreatitis.
So long list of infections. Anything other than infections you will think of?
Malignancy could be a cause. Malignancy, it could be from splenic flexure. It could be from stomach. So malignancy can also be a cause.
So you're a physician or a surgeon?
Sir, I'm a general surgeon.
So think of some physician causes also, no? He has 2 risk factors for vascular disease. Can you think of something else? Any physicians, MD guys?
Dissection of abdominal aorta.
Okay, and something which is more common in elderly people because of ischemic colitis type, huh? You think you should think of ischemic bowel disease also.
So we have divided the causes into structures which are commonly present in the left upper abdomen, such as the splenic flexure, the spleen, the pancreas, and cases of pain which is referred to the left upper abdomen, such as in the kidney and the stomach. Splenic flexure, we have thought of inflammatory bowel disease, ischemic colitis, could be malignancy. Spleen could be hypersplenism, splenic abscess, splenic infarct. Pancreas could be an acute and chronic pancreatitis, pseudocyst pancreas, or a malignancy. Stomach could be gastritis, peptic ulcer disease, or malignancy. Kidney could be pyelonephritis, renal calculi, or a malignancy as well. After this, we moved on to the examination. The patient was examined in a well-lit room with exposure from nipple to mid-thigh with proper informed consent. Patient was conscious, cooperative, and well-oriented to time, place, and person at the time of examination. Patient was well-built and had fair nutritional status. There was no visible pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, peripheral edema. On head-to-toe examination, we noticed that the patient had mild tongue dryness, while the oral cavity was normal. On vital parameters of the patient were as follows. His blood pressure was 94/54 millimeters of mercury in the left brachial artery in supine position. His pulse was 104 beats per minute with normal volume, character, and rhythm in the right radial artery. His respiratory rate was 13 per minute. His type of breathing was thoraco-abdominal. His oxygen saturation was 96% at room air. His temperature was 100 degrees Fahrenheit, and his BMI was calculated to be 21.3 kg per meter square. We first examined the patient's abdomen. On inspection, we noticed that the shape of the abdomen was scaphoid. The umbilicus was inverted and central. The left side of abdomen moved less with respiration. No visible peristalsis or pulsation was present. His flanks were not full. There were no dilated veins, no visible scars or lumps. Hernial orifices were normal, and the scrotum was normal. On palpating, there was no local rise of temperature. The abdomen was soft. There was tenderness in the left hypochondrium. Guarding and rigidity were absent. The spleen and liver were not palpable. There were no other lumps which were palpable. Renal angle was not tender. On percussion, we percussed dull node in the left hypochondrium. There was the liver dullness was percussed in the 6th intercostal space, 2 costal margin, in the right mid-axillary line. His bowel sounds were present and they were normal in frequency. We moved forward with the digital rectal examination, where we noticed a normal anal tone. There were no masses palpable. On the tip of the finger, fecal stain was present, while blood stain was not present.
So two things in the abdominal examination. One, I thought you mentioned that there was reduced respiratory movement on the left side.
Yes, sir.
So that usually happens because the muscles over there are tense.
Yes, sir.
Because of an underlying disease, and to prevent the pain from happening. But then there should have been associated rigidity and guarding also, which you negated.
Yes, sir.
So how do you explain that?
Sir, actually, when we palpated the patient, we noticed that there was less movement. On percussing the left hypochondrium also, we found that it was tender to the patient while percussing that area. However, sir, we couldn't palpate any guarding or rigidity there.
So I thought there is a dichotomy in the findings.
Yes,
you wouldn't have both things together. And did you check for fluid in the abdomen? You didn't mention. You didn't report that.
So we did not percuss with shifting dullness or puddle signs, since the abdomen was not distended. So we thought that yes, a scaphoid abdomen.
If the abdomen is not distended, there can be no fluid? Distension will be present only if there is massive ascites.
Massive ascites, yes, sir.
So a scaphoid abdomen or a non-distended abdomen does not rule out fluid, and even clinical examination cannot detect small amount of fluid. That will be detected only on ultrasound.
Yes,
so as a part of a routine abdominal examination, you have to do percussion for dullness in the flanks, and if there is dullness, then you have to look for shifting dullness. If the abdomen is distended, then of course you elicit fluid thrill also.
Can you percuss here? Well-known area that is reported here is the drop space.
And that is in the left upper quadrant. Whenever there is dullness in this area, one would like to percuss the boundaries of the trob space, and it has clear-cut connotations of what structures will give you dullness in that area. So could you elaborate on that?
The other systemic examinations of the patient were within normal limits. So at this point, I would again like to ask the audience, with the current presentation of the patient, what could be the possible diagnosis? So our first differential was chronic pancreatitis for the patient. We thought of other stomach pathology such as gastritis, peptic ulcer disease or malignancy, and we also thought it could be a splenic infection or an abscess.
1 year history, splenic infection or abscess, very, very unlikely. Either it will resolve or it will complicate.
Yes, sir.
Any infective process going on for 1 year is very, very unlikely.
We created a provisional diagnosis of chronic pancreatitis. Probably the etiology we thought of was alcohol-induced toxic metabolic. After this, we got a radiology.
For your exam, if finally you are going to entertain a diagnosis of chronic pancreatitis, then you have to go back to the history again.
Yes, sir.
Ask some more questions from the patient. What are those questions?
Sir, if there's been any history of pain following an alcoholic binge.
Okay.
So this history was present. Sir, if the pain was in the epigastrium,
Okay.
whether the pain resolved on taking oral medications or required admission, whether it radiated to back.
In addition to pain, what else can chronic pancreatitis cause? Long-standing inflammatory process of the pancreas. What is the pathology of chronic pancreatitis? What happens to the pancreas?
So there is, sir, autolysis, then, sir, followed by
Atrophies.
Atrophies, yes,
The
sir.
parenchymal volume becomes less. So what will that cause?
Steatorrhea.
Yeah. So
Steatorrhea, sir.
even if you did not ask at that time, if finally you are going to give a diagnosis of chronic pancreatitis, you have to go back to the history and ask whether the patient has steatorrhea and
Oil drops after defecation. Oil drops after defecation, sir.
what else? What are the two functions of pancreas? One is exocrine.
Exocrine and endocrine,
So
sir.
you
so
have
diabetes.
Although maybe you mentioned, but you have to specifically say that he is not a known diabetic or there is no recent onset of diabetes. What is steatorrhea?
So it is highly fatty stool, sir.
So how does the patient
Sir,
know
it
that
floats.
he has fat in the stool?
The stool usually floats. Its color is usually paler, and so usually the patient can also complain of oil droplets dropping after defecation, sir.
That depends on what kind of toilet he is using. If it is Indian toilet, how will he see oil droplets?
Yes, sir.
So it is large volume, frothy, pale colored, foul smelling stool which is difficult to flush in an Indian toilet and which floats on water in a Western type of toilet. And if it is severe steatorrhea, an intelligent patient can even notice what you are saying, that there are these like soap bubbles or soap on water. Okay. Sometimes you may not have asked a direct question on history.
Yes, sir.
But depending on what differential diagnosis you are going to mention, you have to go back to the patient and
Retrospective.
ask some questions, leading questions again.
So to confirm a diagnosis, the patient underwent sonography and CCT abdomen. For that, I'd like to call upon Dr. Shailesh Gupta. Sir, first actually we got 2 blood tests done specifically. So that I've mentioned together with the blood test, but I shall mention now. Okay.
Good morning to all the respected teachers and colleagues. I will be taking the radiological findings in this case. First, USG whole abdomen was done and the films are not available. In USG whole abdomen findings, there are small loculated collection in peripancreatic and adjacent distal or body tail region of pancreas are seen. There are hypokic area in splenic parenchyma with perisplenic collection. And the gallbladder is well distended and it is lumen echo-free. Next is CCT abdomen was done, which was done outside, and these are axial post-contrast CT images in which we can see there is a well-defined encapsulated collection seen in distal body region of pancreas, which is extending into lesser sac and causing indentation and compression over the posterior wall of stomach. And thus, this collection is measuring approximately 5 into 4 centimeter in size. Next, these are the post-contrast axial images in which we can see there is a subtle soft tissue stranding seen in the tail region of pancreas and thickening of the left anterior renal fascia. In the next image, there is also another small, well-defined encapsulated collection seen in the tail region, which is extending into splenic hilum and extending to splenic parenchyma up to its periphery. In this, we can see this collection is extending to perisplenic region and which is contiguous with the collection in the left diaphragmatic region. And rest of the pancreas appears normal and shows normal enhancement. There is no intraparenchymal calcification of pancreas and the main pancreatic duct appears normal. And in this, the collection in the lesser sac, there is no internal enhancing septation or solid nodule is seen. And in the peripancreatic region, there is no air pocket is seen. So the suprahead infection is ruled out. Next, these are axial post-contrast images in which splenic vein is mildly attenuated and the splenic vein is not visualized at the splenic hilum, suggestive of intraluminal thrombosis of splenic vein, and there are multiple collateral formations are seen in the splenic hilum and gastrosplenic region. And in this image we can see there are multiple wedge-shaped non-enhancing regions seen in the splenic hilum parenchyma, suggestive of splenic infarcts. So to sum up the radiological findings, there are pseudocyst formation in lesser sac and tail region of pancreas, and which is and loculated collection in pancreatic tail, splenic hilum, and along splenic parenchyma, which is extending to perisplenic region and left subdiaphragmatic region. Next is splenic vein thrombosis with splenic infarcts, and there are bilateral mild pleural effusions, mild ascites is seen, and liver and gallbladder are unremarkable.
Rest of the pancreas, how is it? The head, body?
So head, body, and pancreas, head, body, and proximal part of body are normal. Yes, sir.
Calculi in the pancreatic duct?
No, sir. There is no calculi in the pancreatic duct. Sir, the wall thickness of the collection is 6 mm, and it is indenting and compressing the posterior wall of stomach. So I would like to call Dr. Armaan for further case discussion.
So you said that the patient required hospitalization 1.5 months ago. Why?
So at that time the patient gave a classical history that he went on an alcoholic binge. Following this, he developed a very sharp onset pain, and this was not relieved on taking oral analgesics.
So does your diagnosis change? Does it need to be modified a little bit? What is this episode?
So it is an acute episode.
So this is acute pancreatitis. So
Recurrent
this becomes acute on chronic pancreatitis.
Acute on
there
chronic
is underlying chronic pancreatitis. Although in imaging, as Dr. Saraswat was trying to ask, we haven't seen any evidence of chronic pancreatitis. Neither there is ductal dilatation, nor there is calcification. We didn't see much of the cuts of pancreatic parenchyma, but whether there was atrophy, because these are the signs which would indicate that this is chronic pancreatitis. So far at least, we haven't seen any objective evidence of chronic pancreatitis. So is it that he is having recurrent episodes of acute pancreatitis, which can happen on a background of chronic pancreatitis?
So I will be speaking on further management of the patient. Firstly, the 2 blood investigations that were done in specific to the case. We got serum amyloid and serum lipase levels, which were marginally raised. Other than this, we got a battery of routine tests done for the patient, out of which in which we found that the hemoglobin was low, 8.7 grams per deciliter. Other than this, all other investigations.
Whenever you have a low hemoglobin, you must mention the RBC indices. Is it microscopic? Is it macroscopic? That gives us a lot of idea. Okay?
Yes. So we made a final diagnosis of chronic pancreatitis with pseudocyst formation with the possibility of splenic infarct or a splenic abscess. Patient was planned for laparotomy and proceed with cystogastrostomy and possible splenectomy. Preoperatively, the patient vitals and input-output were monitored. We transfused the patient with 2 units of PRBC. IV antibiotics, analgesics, and antiemetics were administered. Patient was catheterized and nasogastric tube was inserted. He is also advised regarding preoperative prophylactic vaccination. Sir, there is a possible splenectomy in the patient, so we would have prophylactically administered the patient with meningococcal, pneumococcal, and Haemophilus influenzae vaccine. Patient was operated in supine position under general anesthesia in 30-degree head-up position. Upper midline incision was given. Firstly, we found that the omentum was closely adherent to the abdominal wall in the left hypochondrium, as you can see here in the image. Purulent collection was observed in the left hypochondrium, which was toileted and suctioned. A swelling was palpated in the body of the pancreas in close proximity to the posterior wall of the stomach. We incised the anterior wall of the stomach, and a needle with syringe was inserted into the swelling. Aspiration of fluid confirmed the presence of a cyst. After this, we incised the posterior wall of the stomach and drained the cyst, and the patient underwent a cystogastrostomy. Here we can see us suturing the cyst to the posterior wall of the stomach. Now, after moving to the left hypochondrium, we found that there were adhesions on the lateral border of the spleen. On separation, purulent fluid came out of the spleen. This confirmed a ruptured splenic abscess, which was walled off. Here we can see necrotic slough on the spleen and the breached capsule of the spleen. After this, patient underwent a splenectomy, and the spleen specimen was sent for histopathological examination. After hemostasis was confirmed, subsplenic drain was placed, and closure was done in layers. Post-operatively, patient was extubated and sent to ward. Post-operative period was uneventful, and patient was discharged on post-operative day 5. Now, to discuss the histopathology of the spleen, I would like to call upon Dr. Ayushi Punia.
If it is a pseudocyst,
Yes, sir.
so normally जो cysts होती हैं उसको excise करते हैं, sebaceous cyst, ovarian cyst. Why did you not excise this cyst?
So the open duct of the pancreas would cause a pancreatic fistula to form, sir. So we would like to drain it into a hollow viscous.
Why is it called a pseudocyst?
So it doesn't have a true cyst wall. It is not lined by epithelium. Instead, it is lined by a necrotic tissue.
So it is not a true cyst because it doesn't have an epithelial lining.
Yes, sir.
It is only a collection of fluid in a potential space, usually the lesser sac, and the wall is formed by the adjacent organs and the fibrous tissue. So that is why it is almost never excised. Is there a situation where it can be excised?
Sir, if it is at the tail of pancreas, we can do a distal
If it is in
pancreatectomy.
the tail of pancreas.
Yes, sir. Sir, if the tail of pancreas is enclosed, yes, sir. Splenectomy, yes, sir. Splenic vein thrombus. Yes.
It would be nice to get a proper demonstration of the pancreatic anatomy. We have completed the entire procedure, but we really do not
Know what the pancreas is like.
So
The
I'm
disease
asking
comes
to-
from the pancreas, not from the spleen. This is
Yes,
a
sir.
secondary complication that you have got an abscess and which is ruptured. So imaging the distal pancreas, showing if there is chronic pancreatitis, you have a pseudocyst. A good number of them are communicating pseudocysts.
Yes,
So
sir.
and they will recur after this. So until the tail or the site of disease is identified, probably at least an MRCP could have been done
or
to look at the
ERCP.
pancreatic duct clearly, and then accordingly deciding, as Professor Dangaich is saying, that whether a distal pancreatectomy should have been combined with a pancreatic drainage procedure along with the splenectomy rather than simply tackling the spleen and draining the abscess.
Yes, sir.
Good morning, my teachers and my colleagues. Today I am going to represent histopathology of spleen. We received splenectomy specimen in pathology department in 2 pieces, conjointly measuring 14 into 8.3 into 4 centimeter. Externally, grey brown with yellowish areas measuring 6 into 5.5 into 4.3 centimeter. Cut surface predominantly grey brown with few yellowish necrotic areas. Microscopic of normal spleen shows outer layer is capsule, trabeculae, red pulp that filters damaged RBCs through sinusoids, and white pulp forms sheets of lymphoid cells that is composed of T cells and lymphoid follicles, that is B cells. And this splenectomy specimen microscopy shows dilated sinusoids with sparse lymphoid follicles. Necrosis with acute inflammatory cells, that is neutrophils. Congested venous sinusoids. Subcapsular area shows inflammatory exudate, that is neutrophils. And features are suggestive of acute inflammatory lesion, that is abscess. And now I would like to call Dr. Armaan.
The spleen was removed en bloc. So you have the splenic vein, splenic artery. Splenic abscesses normally would appear not in a splenic vein thrombosis, but if the arteries are also blocked.
Yes, sir.
So do we have any evidence of disease affecting the vessels?
Yes, sir. Vessel.
The vessels were not received. Were not in the spleen. The resected specimen did not contain the.
So now I'll be moving on to review of literature. So firstly, I'd like to present a case series presented in the British Journal of Surgery. In this chronic pancreatitis patients, 500 patients were followed for 7 years prospectively. 2.2% of the patient had splenic complications, with only 0.8% of the series coming with splenic rupture. Out of the 2.2% that had splenic complications, it was found that 86.4% of the patients had history of alcohol intake. The author also concluded that surgical treatment in splenic complications is usually necessary. Next, here is a case report posted in the Asian Journal of Surgery in July 2024. The author has said that if the pancreatic tail is closely adherent to the splenic hilum, it can be an anatomical foundation for splenic rupture in pancreatitis. It can cause the pancreatic exudate more likely to invade the spleen directly. In radiology case reports in 2023, non-traumatic paper was published, case report, non-traumatic splenic rupture and pancreatic pseudocyst as a complication of pancreatitis, a case report. In this, the author has said that there can be different mechanisms through which splenic rupture can occur secondary to pancreatitis and pseudocysts, including perisplenic adhesions, diffusions of proteolytic enzymes to the splenic hilum, secondary to splenic vein thrombosis, or due to acute inflammation. In 2016, a case report was published, a case of chronic pancreatitic pseudocyst causing atraumatic splenic rupture without evidence of acute pancreatitis. In this, the author has said that the rupture of spleen is a well-documented finding event and is mostly associated with blunt trauma. However, in the case of chronic pancreatitis, 65 cases have been reported in literature with splenic rupture due to atraumatic causes. And finally, in 2015, a case report was published in International Journal of Surgery, which said occult splenic rupture in a case of chronic calcific pancreatitis, with a brief review of literature. In this, the author has said that the splenic rupture in chronic pancreatitis, though exceedingly rare, is a life-threatening complication. So the take-home message for a surgeon: atraumatic splenic rupture is a rare complication of pancreatitis, but should be surveyed for, and it requires immediate surgical intervention. I would like to extend my heartfelt gratitude to the management of MGUMST for giving us this platform to present such a case, the CCR review committee for coming again and again and eventually improving our CCR so much, the Department of Radiology and the Department of Pathology for participating in our CCR, and the patient and his attendants for constantly inspiring us to learn medicine and go forward.